All right, welcome, colleagues. I thought I heard the voice of the president of Canexa, Dr. Mpoki. It's a privilege to have you here. So, welcome. And we're going to tonight look at vasoactive agents or drugs that we employ in the intensive care unit. And we're going to look at our learning outcomes. Okay, so our learning outcomes, I have 5 of them. We hope at the end of the lecture we would understand the mechanism of action, the pharmacokinetics and pharmacodynamics of the various vasoactive agents that we commonly use in the ICU. We hope also that we should achieve um, ability to recognize clinical scenarios that necessitate the use of vasoactive agents. We should be able to implement appropriate dosing regimens and titration strategies for different vasoactive drugs. Be able to understand and utilize clinical and hemodynamic parameters to assess the efficacy of our agents. And we should also be able to identify and manage common side effects associated with these agents. All right, so this is the outline we're going to be following. All right, so by way of introduction, vasoactive drugs or agents are very important drugs that are usually employed in the management of our patients in the ICU. You and I know that they play a significant role in the management of hemodynamic instability in our patients, ranging from sepsis to cardiogenic shock, decompensated heart failure, and the rest. So they are essential for optimizing cardiovascular function, ensuring adequate tissue perfusion in these various clinical conditions I mentioned. So what are vasoactive agents? All right, if you look at the word vaso, it means that these are drugs that affect the vasomotor tone, all right, which is an important factor that determines blood pressure and mean arterial pressure. So these drugs are drugs that act primarily to affect the vasomotor tone, all right, the blood vessels and the heart itself. And they are divided mainly into 3: the inotropes, the vasoconstrictors, and the vasodilators. Hopefully, we should be able to run through these 3 different categories of vasoactive drugs in the ICU. All right, so we'll just remind ourselves a little bit of physiology so that we can understand how these agents work. So the first terminology or term we're going to be looking at is cardiac output. And we know that this is the volume of blood that the left ventricle pumps out every minute. All right, and it is a critical determinant of our tissue perfusion, and it is calculated as cardiac output, which is equal to heart rate and strokes volume. The heart rate itself is the number of heartbeats per minute, and the stroke volume is that amount of blood ejected by the left ventricle by each cardiac cycle. Inotropes, as we know it, increase myocardial contractility, and this therefore enhance stroke volume and cardiac output at the end of the day. Chronotropes alter heart rates, either negative chronotropes or positive chronotropes. And from the mathematical formula we have above, changes in heart rates will eventually influence our cardiac output. The second term we're going to look at or remind ourselves about is systemic vascular resistance. All right, as the blood flows through the different blood vessels, tissues, and organs, they encounter resistance. And this resistance is influenced by the tone of the blood vessels, especially the arteries. And from our calculation of cardiac blood pressure, which is equal to cardiac output multiplied by systemic vascular resistance, we say that systemic vascular resistance will just be blood pressure over cardiac output. Now, our vasoactive agents that affect the vasomotor tones, thereby determining systemic vascular resistance, include vasopressors, and they do this by causing vasoconstriction and help to maintain or increase systemic vascular resistance, and by so doing, increases our blood pressure. All right, vasodilators, on the other hand, decrease systemic vascular resistance, causing vasodilatation, and this helps to reduce afterload, the pressure that the heart needs to overcome in pumping blood to the systemic circulation. And the vasodilators are vasoactive agents that are helpful in managing conditions like heart failure and hypertensive emergencies. And these are conditions that we commonly encounter either in the OR or in our different ICUs. Yeah, another very important concept that we need to remind ourselves of is mean arterial pressure. All right, and I like this graph on the right side of the screen. Now, most of the times we look at blood pressure, which is systolic over diastolic, but in the face of fluctuations, blood pressure fluctuations, and critical illness, measuring blood pressure, paying attention to blood pressure alone is not enough. So we need to look at the mean arterial pressure, which refers to the average pressure, all right, in the arteries during a single cardiac cycle. Now, if you look at this is the systolic blood pressure with the diacritic notch. This is the diastolic. So this is an arterial waveform, all right, and where we have the systolic here and the diastolic here. Now, the mean arterial pressure is this one here, this line. This is the average of the pressures during both systolic and diastolic functions. And if you look at this graph very carefully, you will see that the mean arterial pressure is about 1/3 of the systolic blood pressure. If you look at it, if you divide it, it's about 1/3 of the systolic blood pressure, and it's about twice the diastolic pressure, if you look at it very well. So the mean arterial pressure is actually the one that we should pay attention to in our ICU, especially in critical conditions of our patient. What it does is that it helps to ensure the perfusion of our different tissues. The pressure that actually ensures that our different tissues and organs are well perfused is the mean arterial pressure. And most of the times, if you look at the surviving sepsis campaign, and the goal, the early goal directed therapy, one of them is you want to ensure that your mean arterial pressure is above 65 at all times, because it is at this pressure that you can guarantee and ensure adequate perfusion of your tissues. So most of the times when I do round in the ICU, I'm more particular about what the multi-parameter monitor is giving me concerning mean arterial pressure. Another thing, even in health, during exercise, when you have very varied fluctuation in blood pressure, what is more important is actually the mean arterial pressure. So there are different mathematical formulas that can be used, but for me it's easy if you look at it from the graph that the mean arterial pressure is about 1/3 of the systolic blood pressure and twice the diastolic pressure. And you can actually use that to calculate whatever mathematical formula you want to use. All right, so the third, terms that I want us to look at is the term preload. I saw this on the internet, and it's beautiful. I just felt I should just include it here. If you look at the diagram on the right side of the screen, you'll see the preload as if somebody is pouring fluid or whatever it is into the heart, into the right side of the heart, the right atrium. All right, so this is the preload. It refers to the tension of the ventricles, all right, at the end of diastole, all right. So, and this is, influenced by the volume of blood in the ventricles at the end of diastole. All right, so it determines a lot, plays a significant role in our blood pressure, especially mean arterial pressure. And this preload is influenced by the Frank Stanley mechanisms, all right, or rules or laws, which talks about the degree of stretch of an elastable tissue determines the pressure that excitable tissues will exert. So this is the preload. This refers to the blood returning by, we call it venous return from the other parts of the body. And if you look at the afterload, this is your left ventricular outflow tract, all right, from the aortic root and all. So this refers to the pressure that the left ventricle must, overcome in order to pump blood into the systemic circulation. So the resistance that the left ventricles must overcome, all right, is known as the afterload. All right, this afterload is primarily determined by your systemic vascular resistance and semilunar valvular damage. So if you have aortic stenosis or any stenosis along or valvular stenosis along this tract, the afterload will increase, and this will reduce the blood pressure that you're going to perfuse your organs or the patient's tissues with. All right, the next very important terminology as it relates with our cardiac function and vasomotor tone is contractility and lucitropy. All right, so the myocardial fibers of the heart has intrinsic ability to contract, and this is independent of preload or afterload, but can be influenced like with your inotropes. All right, maybe for instance, if you are using noradrenaline or mirelone or any of these vasoactive agents, they act, or especially the levosmidan, the calcium sensitizers. What they do is that they increase the intrinsic ability of the heart to contract, and that affects your stroke volume and eventually your cardiac output. Lucitropy is the ability of the myocardium to relax during diastole, and this is important because optimal lucitropy ensures proper ventricular filling. Don't forget, two things are very important here. The ability of the heart to be refilled with blood after contraction depends on the optimal lusotropic property of the heart. And don't forget also that your heart, gets perfused during diastole. So lusotropy is very important as it ensures proper filling of your ventricles and ensures coronary perfusion. So this diagram here, it shows us, all right, this is end diastolic volume, all right. So when there's increased relaxation during diastole, we have what we call increased lucitropy, all right. And when the heart contracts, this is at the end of systolic, all right, contraction, and you have increased lucitropy, you have the pressure is higher, all right, and it moves the graph moves a little to the left, and you have increased inotropy rather, which is contractility. Relaxation is when there's more, all right, from the end diastolic volume, and this is very important. Both of them are crucial, but this is important because it determines the filling pressure of the ventricles and ensures adequate coronary perfusion. All right, another aspect, many of us, we do not actually think about this when we're giving our vasoactive agents, but indeed, vasoactive agent also helps to ensure optimal oxygen delivery to the tissues, all right, by ensuring adequate cardiac output and perfusion pressure. All right, so this works, the oxygen delivery, especially if you remember physiology, all right, this adequate oxygen delivery is vital for cellular function, and the formula is oxygen delivery is equal to cardiac output and the oxygen content of the blood that reaches the tissues, and the oxygen content is given mathematically as it depends on the hemoglobin concentration of the blood and the arterial oxygen saturation. So the PaO2, the oxygen saturation, they all combine to give you adequate oxygen delivery to the tissues, oxygen delivery and actually utilization. Now, if you look at this diagram on the right, it depicts very beautifully. If you look at the amount of oxygen that is delivered to the tissue is dependent on the cardiac output, which is also dependent on the heart rate and the stroke volume. The stroke volume is dependent on both the preload, the cardiac function, and the afterload. And the oxygen content, all right, of the arterial blood being delivered is dependent on the hemoglobin and the oxygen saturation of the blood. All right, so we look at definition of terms. I'm sure we're all familiar with this. We won't spend too much time here because we have a lot to talk about. So inotrope is any agent that alters the force of muscular contraction, especially on the heart. Vasopressor increases systemic vascular resistance due to vasoconstriction and causing an increase in blood pressure. Vasodilator does the opposite. Chronotropes alters the rate of irregularly occurring phenomena such as a heartbeat. Inodilator or vasodilator. Inodilator is actually a combination of agents like Mirinone or what's it called? Mirinone, which is a phosphodiesterase inhibitor. All right, it has both inotropic and vasodilator effect. Lucitropes are drugs that causes relaxation of the cardiac muscles and chambers. Donotrop, really, most of our vasoactive agents do not have donotropic effect because this ones cause alteration in impulse conduction along the electrical, fibers of the heart. All right, so let's go down now to our vasoactive drugs. Indeed, so we have different types. The catecholamines, the vasopressors, phosphodiesterase inhibitors, and you have your calcium sensitizers. All right, so under the catecholamines, we have the adrenaline or epinephrine, noradrenaline, dopamine, dobutamine. Vasopressors include phenylephrine, metaraminone, ephedrine, and vasopressin. Phosphodiesterase inhibitors include mirinone, amiodarone, and noximone. And we have calcium sensitizers, the limosmidan and the glucagon. All right, I don't know if you can see this. We'll just go through that. Now, so the classifications of vasoconstrictors, we have those who are pure primary duties vasoconstriction, and this includes agents like phenylephrine, vasopressin, and metaraminone. They are pure vasoconstrictors. They act on the vascular smooth muscles of the blood vessels. The combined vasoconstrictors or inotropes, the noradrenaline, adrenaline, we're going to be looking at them because the activity is determined by the receptors that they primarily act on. Now we have the vasodilators, we have the pure vasodilators, and like I mentioned, the combined vasodilators and either negative inotrope or negative or positive inotrope, like your enoximone or mirinone. So vasoconstrictors, how do they act? They stimulate the peripheral alpha adrenergic receptors. Phenylephrine is the number one example here because phenylephrine is a pure alpha 1 adrenergic receptor agonist. All right, we have other vasoconstrictors like vasopressin that stimulate the V1 receptors, all right, and the direct cardiac effect, all right, via receptors, ion chambers, and enzymes in the heart, like the levosmidan, which increases the impact of troponin C on cardiac fibers. Vasodilators primarily stimulate peripheral beta-2 adrenergic receptors. Some antagonize alpha receptors. Those of us have had I've handled cases like pheochromocytoma. You're familiar with phentolamine. We have others that cause vasoconstrictors by the antagonism of the calcium channel blockers. Others stimulate dopaminergic receptors, and others inhibit the cyclic AMP breakdown, like the enosimon. All right, so the receptors, there are about 7 receptors that our vasoactive agents act on. The first one is the alpha 1 receptors, and these receptors are located in the vascular smooth muscles and in the myocardium. Alpha 2 receptors are located more in the larger blood vessels, while B1 receptors increase heart rate and myocardial contractility, while B2 receptors activation will lead to vasodilatation, bronchodilation, uterine and GI relaxation. The dopaminergic receptors, the dopaminergic agents actually act both on the neural, cardiac, and the renal, tissues, and they have from D1 to D5. But D1, D5 receptors cause excitation as they increase cyclic AMP formation, all right, and leads to phosphodiesterase 2 hydrolysis. All right, they do D2, D4 receptors they are inhibitory, and they cause vasodilatation, reducing systemic vascular resistance. Your vasopressin receptors activation causes a change both in your vascular tone and the renals. All right, remember that vasopressin is actually an antidiuretic hormone, so it has both effects on the vessel, on your vessels, and on the kidneys. All right, this is just for those of all who have the slides to just go through it later on, but this is exactly what I have been talking about in the previous slides. All right, if you look at it, I don't know if you can see this slide very well. You will see that, let me see if this one can leave here. So this talks about more of the activities. All right, if you look at this alpha 1, beta 1, and all that, I can see all the way up. But alpha 1, you see phenylephrine has major alpha 1 activity. All right, and that is why it's very important, very useful in sepsis, and especially in vasodilatory shock. We have epinephrine has effect on alpha 1, beta 1, and some activities on the other receptors. All right, and this is important, especially in choosing the type of vasopressor or vasoactive agent you want to use. Dobutamine has lesser alpha 1 receptor stimulation compared to dopamine, although dopamine has dose dependent effect on the different receptors. And so we will just familiarize ourselves with this, because a lot of times you want to decide which vasopressor is best for this patient. For instance, we know that phenylephrine causes causes bradycardia. So for patients that you do not want tachycardia, but you want to increase tissue perfusion, phenylephrine may even be the best. And as we go on, you will find out from some studies another benefit of phenylephrine over norepinephrine, especially in our mechanically ventilated patients. All right, so we mentioned this before. We'll just go on. This is just a repetition diagram to reinforce what we've talked about. All right, vasopressin has some V1 receptors, and we talked about this. So what are the indications for inotropic support? Various indications, it starts from your cardiogenic shock, all right, which is defined as reduced tissue perfusion, primarily due to cardiac dysfunction, septic shock, heart failure, pulmonary hypertension, post-operative, after open heart surgery, major surgery, and all of that. These are some of the indications for vasoactive support or inotropic support in our patients. All right, so we look at the dose. We'll come back to this dose as we go on. Vasodilators are different types. So let's look at the different agents that we have in our armamentarium in the ICU. The first one that we're very familiar with is adrenaline or epinephrine. All right. So at low doses, adrenaline is mainly a beta agonist, B1 agonist. But as you increase the dose of your adrenaline, you have more of alpha 1 agonist activities. All right. So the stimulation of myocardial B1 and B2 adrenergic receptors causes an increase in contractility and heart rate. And this is how adrenaline helps to augment cardiac output, because it affects both the contractility of the myocardium and the heart rate. All right, heart rate is further augmented by adrenaline due to an increase in venous return, and this is due to a stimulation of vasoconstriction through its alpha-1 activity. Adrenaline is common, indicated in different clinical scenario, and we need to understand the dilution. All right, so your 1 in 1,000 adrenaline will give you 1 microgram per kg, per meal rather, one microgram per meal. And if you're having 1 in 10,000, that'll give you 0.1, and 1 in 100,000 will give you 0.01 microgram per kg per minute. And so the normal dose we use is 0.01 to 0.05 microgram per kg per minute. And this is crucial because as you look at it, the dose that you are given will determine the kind of effect that your drug will have on the heart. So if you look at it, for inotropic support, if it depends on the concentration that you're using, if you're using 1 in 100,000, 1 microgram per kg per minute will be 0.1 milligram per kg. And for resuscitation, especially during CPR or cardiac arrest, following cardiac arrest, you want to use a stronger concentration, the 1 in 10,000, and you have 0.1 mil per kg in this group of patients. Remember that with higher doses, like I mentioned, we have more of alpha-1 agonist activity or stimulation, and this can lead to vasoconstriction of precapillary resistance vessels of the skin. I've seen patients who develop limb ischemia from high doses of adrenaline use in ICU. Noradrenaline is more of an alpha agonist, majorly. It has some B1 agonist activity. And because of its dominant alpha agonist activity, it is the preferred vasopressor in septic shock. All right. And another thing is that it tends to preserve renal blood flow compared to your adrenaline. Remember that because it's a vasoactive agent, it should always be given right along the central line. The most unwanted side effect of adrenaline, obviously, is vasoconstriction and organ hypoperfusion as relates with our, especially the splanchnic blood flow. It's also given at a rate of 0.05 to 0.15 microgram per kg per minute. It depends if you're using, a syringe pump or syringe drivers. It is better you can put 4 milligram, all right, 4 ampoules of your noradrenaline, 15 mils of 5% dextrose, and you titrate to effect if you are using, syringe drivers or syringe pumps in the ICU. Otherwise, you can constitute it in your 500 or 250 mils of your dextrose or normal saline, and you titrate it according to your calculated dose. All right, phenylephrine, I mentioned before, is a synthetic sympathomimetic amine, all right, that has a selective effect on your alpha-1 adrenergic receptors. Know that as blood pressure rises in this patient, there's an activation of vagal reflexes which causes bradycardia. All right, and this is important. This is useful in patients that you do not want tachycardia, or tachycardia can worsen their cardiac effect or their outcome. Phenylephrine is commonly used, especially in the OR, like I mentioned, especially in obstetrics, anesthesia-induced hypotension and patients with hyperdynamic septic shock, all right, with tachycardia and all that high output cardiac output. I mean, high output septic shock. It has a rapid onset of action. The duration is short, and primarily vascular effect make it an ideal agent in the ICU setting. All right, like I mentioned, it's an attractive agent when you do not want tachycardia, but you want your tissue perfusion to be increased. You can give it a dose of 50 to 100 microgram per minute as a bolus, and as a continuous infusion as 0.5 to 1 microgram per kg per minute. All right, ephedrine, most of the times, I remember when I started residency, some 2002, 2003, thereabout, ephedrine was a common drug. You can't do a spinal in theater without having ephedrine. I know it has fallen out of disfavor because of its effect on causing myocardial ischemia, but in resource constrained environments, ephedrine is still very useful, but not primarily in the ICU. I just brought it in for us to know that it's also a vasoconstrictor, although a non-selective one for that matter. All right, it has a direct non-selective activation of adrenergic receptors, and it also causes a release of noradrenaline from storage site. It is less potent, but lasts longer than adrenaline, and it has similar hemodynamic properties, cardiac stimulation, and peripheral vasoconstriction. It was a darling of obstetric anesthetists because it was found not to compromise uterine blood flow, and that's why it was heavily used those days. Dose is 10 to 25 milligram bolus, and you can give repeat your dose every 5 to 10 minutes. But remember, like I said, it's falling out of favor with a lot of anesthetists, and is not commonly used. It's not commonly used in the intensive care unit setting. Isoproteinorol is a synthetic sympathomimetic amine, and it has potent non-selective beta-adrenergic activity with little effect on alpha receptors. All right, it causes increased cardiac output due to its positive inotropic and chronotropic effect. So it increases myocardial contractility and also increases heart rate. All right, its use is limited, as a temporary measure for hemodynamically significant bradycardia that is unresponsive to atropine because of its chronotropic effect. All right, while you're waiting for a more definitive treatment like external or transvenous pacemaker insertion. Don't forget that it has both systemic and pulmonary effect due to its beta-2 mediated vasodilatation in skeletal muscle and pulmonary vasculature, respectively. All right, vasopressin. According to the revised guideline of advanced cardiac life support, vasopressin has been advocated as an alternative to epinephrine for the treatment of adult shock refractory ventricular fibrillation. But apart from that, vasopressin has found use, especially in ICU, as an adjuvant, all right, to our commonly used vasopressors like noradrenaline. All right, it acts mainly by binding to V1 receptors on smooth vascular muscle cells. All right, although it has minimal pressor activity in healthy subjects, it has been shown to improve blood pressure in patients with sepsis, and especially patients who suffer vasodilatory shock after cardiopulmonary bypass. All right, and although it is not commonly used, but it's been found to be effective, even as much as effective in the treatment of cardiac arrest, especially those who are unresponsive to adrenaline and defibrillation. So vasopressin, it's been recommended, and if you've got it in your center, I recommend that you use it, especially as an adjuvant, not a standalone vasopressor, especially for refractory septic shock. Dopamine also looks like a drug that has fallen out of favor I remember during my, when I started training, dopamine and ephedrine were the must have, especially as part of your resuscitative drugs in the ICU. I remember the first time I saw lobotomy was in sometime in 2005 or thereabout. So dopamine was actually very useful and saved a lot of lives. So one of the very important thing about it that it causes a dose-dependent effect on the vascular system. In low doses, doses like less than 3 microgram per kg per minute, dopamine activates dopamine receptors in the kidneys and splenic circulations. I remember those days we used to use it to augment, patients who have acute kidney injury. I'm aware that the KDIGO, the kidney disease global outcome criteria, it's categorically stated that dopamine should not be used to improve renal function. So between 3 to 10 microgram per kg per minute, dopamine adds some beta receptors in the heart, all right, which leads to increased myocardial contractility. Above 10 microgram per kg per minute, it acts as a vasopressor, all right, causing both systemic and pulmonary vasoconstriction. All right, its beta agonist activity makes it still relevant, especially in the ICU when we do not have alternatives. And like I wrote here, I said the only clinical use of dopamine now is cardiac stimulation and peripheral vasoconstriction at intermittent doses. One of the reasons why dopamine has fallen out of favor is because of the side effects, which includes tachyarrhythmia, digital gangrene. It can cause raised intraocular pressure and delay gastric emptying. So you put 200 milligram in 50 ml of dextrose water and you titrate to effect. Dobutamine, yes, dobutamine. Anytime I remember dobutamine, I remember double. All right, dobutamine has double effect. All right, it's both a potent B1 agonist and a weak beta 2 agonist. All right, it is effective in both right-sided and left-sided heart failure because of its inotropic and chronotropic effect. Note that because of its chronotropic effect, is contraindicated in hypertrophic cardiomyopathy, and it's not recommended, so to say, to be used alone in the management of cardiogenic shock. All right, some of the common side effects of dobutamine is it's malignant tachyarrhythmia, which seems to be rare. And another thing for us to note about dobutamine is that in as much as it causes myocardial contractility due to its inotropic effect, it also causes vasodilatation of your systemic vasculature. So, in as much as it is helping myocardial contractility, it causes a reduction in afterload, and all you have is improved cardiac output. All right, those ranges between 3 to 5 microgram per kg per minute, and sometimes a lot of times higher doses may be required, especially in decompensated heart failure. All right, because of our time, this is just a diagram to show you how some of these inotropic drugs work. All right, like the botamine acts with on your beta receptors, and digoxin acts on both calcium and potassium sodium exchanger receptors, and your phosphodiesterase enzymes inhibitor here lead to cyclic AMP, activity increasing, it leading to a rise in cellular calcium, causing increased myocardiac or myofibric contractility. All right, this is just for those of us who are interested to look at it more closely. Levosmidan is it's no longer new those days. Like maybe 10 years ago, we would have said it's new. It's a pyridazone dinitrilene derivative. All right, it has two very important actions. All right, number one, it enhances cardiac contraction via its calcium sensitization. And what it does is that it opens, it makes the myocardium more responsive, your troponin C, all right, and the calcium contractility. Calcium sensitization leads to increased myocardial contractility. It also causes arterial, coronary, and venous dilatation by opening the ATP sensitive potassium channels. Know that is about 98% bound to plasma protein and is completely metabolized. All right, it's given at a dose of 6 to 12 microgram per kg over 10 minutes, and as infusion you can give 0.05 to 0.2 microgram per kg per minute. One of its commonest side effects are headaches and hypotension. All right, so let's look at the specific indications where we make use of our vasoactive agents. Obviously, as intensivists and those of us who work commonly in the or more in ICU, even in the OR, sepsis and septic shock seems to top the number one indication for vasopressor use. All right, and like we mentioned before, because is primarily acts more on the alpha receptors. Norepinephrine or noradrenaline is our first line agent to be deployed in dealing with vasopressor. Vasopressin, like I mentioned, can be used as an adjuvant, all right, to increase vascular tone and reduce your noradrenaline requirement. We did say that noradrenaline can cause reduction in peripheral tissue perfusion. And like I mentioned before, we have cases of patients requiring high doses of norepinephrine but developing digital ischemia. And those of them who are on enteral nutrition may cause enteral nutrition intolerance. So, in order to reduce the dose of your noradrenaline or norepinephrine, vasopressin comes handy. All right, epinephrine comes a distant third in our choice and is actually added, all right, as a second vasopressor or even third vasopressor for patients who have refractory septic shock. Really, I've added dobutamine, as my third agent, all right, when we have echocardiography evidence of myocardial dysfunction, patients with ejection fraction less than 40, and they're having low cardiac output despite your maximum doses of vasopressor. Dobutamine helps to increase cardiac contractility and reduces afterload, making cardiac output more achievable or readily more achievable. But note that by the time you are getting to add dobutamine to your patient in septic shock, the outcome really does not look good, especially with underlying myocardial dysfunction. Yeah, we take care of patients, especially those cardiogenic shock, all right, and inotropes are the first drugs to be deployed. We have dobutamine and Mirinon, which is the phosphodiesterase inhibitor. Epinephrine can be used sometimes in more than, according to the literature, more than 90% of patients with cardiogenic shock will require an add-on noradrenaline to maintain blood pressure, especially in the face of refractory hypotension. Patients with severe heart failure, all right, you want to use both your inotropes and vasodilators. Your inotrope will increase cardiac output by enhancing cardiac contractility, while your vasodilators, the pure vasodilators like your nitroglycerin and your sodium nitroprusside, will lower both your preload and your afterload. And the beauty of nitroglycerin is that it also helps to reduce myocardial oxygen consumption, all right, and this helps especially in severe heart failure. Post-cardiac surgery, cardiac anesthetists are very used to all this, all right, the use of dobutamine, vasopressor, and vasodilators. These are parts of the armamentarium of the drugs they have during cardiac surgery, and especially post cardiopulmonary bypass. Once the patient comes off bypass, you want to ensure that all of these vasoactive agents are readily available in the cardiac ICU. All right, so There are some controversies I just want to bring to our attention. All right, the use of vasopressors, with enteral feeding. No, if we look at it per se, vasopressor does not impair enteral nutrition. But we do know that because of its vasoconstriction or vasoconstrictive activity, they do reduce plasmic blood flow and therefore gut perfusion. And so, quite a number of people, because of this, tend to worry about the risk of vasopressor and enteral feeding. All right. Most of the times, the way out, some clinicians delay enteral nutrition till the patient is hemodynamically stable, which makes sense. You can give your patients TPN, total parenteral nutrition, while your patient is on high doses of vasopressor, especially noradrenaline, and some that like we say, if the gut is working, use it. Early enteral nutrition is indicated in some situations, and you want to start with low volume and you increase gradually. All right. Another things we do is we make use of prokinetics, which helps, especially in cases of feed intolerance. And you can actually adjust your dose of vasopressors, and you can have add on. So vasopressor per se is not a contraindication to early enteral feeding. We just need to look at case by case, merit, so that we know exactly what to do. If you're interested in reading more of the studies, I have the reference at the bottom of this slide. It actually goes to show a lot, especially concerning the use of vasopressors with enteral feeding. Another very important consideration is the use of vasopressor in a mechanically ventilated patient. Wolfers et al. Documented that those patients who are mechanical ventilator requiring vasopressor therapy had more than threefold increase in their also developing weakness and muscle weakness. All right, and once this happens, they stay longer on ventilator, they stay longer in the ICU, and they have poorer outcome. In fact, the study documented that each day that a patient received a vasoactive medication, they also developing weakness increased by as much as 35%. That also shows that it depends on the vasopressor you are using. For those with beta-adrenergic receptors, the norepinephrine and epinephrine, they are more associated with weakness. In fact, it's found out that the incidence of ICU-associated weakness increased along with the cumulative dose of norepinephrine that is used. But they found out that those patients who were on vasopressin and phenylephrine, the incidence of ICU-associated weakness is not significant. So what do we do? The question is, what is the best practice? We have a ghost winning criteria that we use in all the ICUs that have worked, and it's a good practice to wean your patient off the suppressor before you start weaning them off the ventilator. All right, the ghost winning criteria is something I developed, and it has helped in assessing readiness to wean from the ventilator. G talks about GCS. At least your GCS should be greater than 10T, all right, before you start considering to wean your patient off. And this comes very handy in association with other well-established criteria for weaning off the ventilator. H, the patient must be hemodynamically stable, that is achieving MAP above 65 without inotropic support or vasopressor support. And this is why it's important that we wean the patient off vasopressor before you start weaning off the ventilator. I think it's a good practice for us to consider. The O talks about oxygenation. S talks about the patient must have passed your spontaneous breathing trial or your rapid shallow breathing index score, and the patient must have a temperature less than 37.5. At least the patient is not febrile. So this is some of the you know controversies and contributions about use of vasopressors in patients who are on mechanical ventilation. All right, vasopressor. We can't talk about vasopressor. Our time is getting up. We can't talk about vasopressor without talking about vasodilators, and we mentioned them actually. All right, I'm just going to go over some of the conditions where vasodilators are used in the ICU. All right, number one is hypertensive crisis. All right, don't forget that hypertensive crisis can be divided into two: hypertensive urgency and hypertensive emergencies. All right, hypertensive urgencies refers to blood pressure greater than 1/80, 180 over 110, but there's no evidence of acute organ damage. All right, hypertensive emergencies is blood pressure greater than 180 over 120 with evidence of acute end organ damage like renal compromise, like stroke, and all that. So when there's an evidence of end organ damage, is known as hypertensive emergencies, and that's why we are concerned here. The goal in the management of hypertensive emergency is to gradually reduce the mean arterial pressure by not more than 1/4 within the first hour. You don't want to bring down the blood pressure too fast, and then you gradually go over it over 2 to 6 hours and over 24 to 48 hours. The agents that are commonly used are the sodium nitroprusside, labetalol, and hydralazine. And I need to say something about labetalol because it's a common vasodilators that we use in management of hypertensive emergencies, especially our neuro patients that come with subarachnoid hemorrhage, from maybe aneurysm and rupture or whatever it is that they could have. So labetalol comes handy, and we need to remember that it's a mixed alpha and beta adrenergic antagonist. All right, it works both at the alpha 1 and beta receptors, causing reductions in systemic vascular resistance and thus blood pressure. All right, its beta adrenergic blocking effect also decrease heart rate and myocardial contractility, further contributing to blood pressure reduction without a significant reflex tachycardia, and that is why it comes handy here. All right, it's indicated in hypertensive emergencies to prevent or reduce end organ damage post-operatively, especially for patients who have undergone vascular or cardiac surgery. Don't forget our obstetric population. Labetalol comes handy, in the management of severe hypertension from preeclampsia or eclampsia. And this is the usual dose that we give. But I like limonene. So if you look at the side effects of labetalol, the side effects of labetalol is actually labetalol. All right, liver injury, although it's rare, but can happen, and it's important for patients who want prolonged labetalol therapy, especially our obstetrics patient, preeclampsia and eclamptic patient. You need to monitor liver function tests. It can cause bronchospasm, especially in patients with history of hyperactive airway, asthma, and COPD patient. It can cause bradycardia, significant enough to cause hemodynamic compromise. All right, it can cause allergic reactions and lethargy in most of the patients that are on prolonged therapy with labetalol. All right, sometimes we have patients with pulmonary artery hypertension, all right, pulmonary hypertension, all right, and don't forget that you use your echo to assess the right ventricular size and function, all right, and cardiac catheterization helps to make the diagnosis. But the management of pulmonary hypertension is PPE. We use the prostacyclin analog, which is studies have shown that is the first choice in the management of pulmonary hypertension. You give a continuous IV infusion because it has a very short half-life, and you start with 2 nanogram per kg per minute. Phosphodiesterase 5 inhibitors like sildenafil inhibits degradation of cyclic GMP, which leads to vasodilatation. The newer ones, the endothelin receptor antagonists, your bocetan all right, it can be used, but bosetan is a dual endothelial receptor antagonist. We have the specific one, the selective one, the abrisetan, and these are common drugs that are useful in the management of pulmonary arterial hypertension. Yeah, ischemic heart disease, we can be categorized into three: the stable angina, unstable angina, and your myocardial infarction. All right, myocardial infarction can be worse, especially in diabetic patients, because of peripheral neuropathy. They can have silent MI, and part of the management of MI are the use of vasodilators. We have the nitrates, the short acting and the long acting. And a lot of times, some of these patients come to us after revascularization procedures, but many of them are on vasodilator therapy. And this is important, and that's why I felt it's important for us to quickly remind ourselves of use here. This table shows us some of the agents that are indicated in hypertensive crisis or emergencies. For patients with hypertensive encephalopathy, you want to use your sodium nitroprusside, your nicardipine, all right, because of vasospasm, and your labetalol, which is a very, very fast acting vasodilator. Malignant hypertension, all right, stroke patients, patients with myocardial infarction, like I mentioned, aortic dissection, adrenergic crisis, all right, especially following your pheochromocytoma surgery, patients with postoperative hypertension. These are some of the conditions where you use vasodilator therapy. All right, these are just doses I put here, and I mentioned this here. So, for sake of studies, I just brought some studies here, and these studies that was published in 2018, about 6 years ago, show that epinephrine, adrenaline, and vasopressin acted appropriate second-line vasopressor therapy. All right, they should be used as second line, and may enable use of lower doses of norepinephrine. So it's important, don't be shy to add vasopressin to your norepinephrine in improving your hemodynamic status for your patient in sepsis. And sometimes inotropes like dobutamine can be added, like I mentioned, especially in patients with documented cardiac dysfunction. All right. This is just about the study. There's this other study, but because of our time, I would like to just leave that here. All right. The FDA had approved angiotensin 2. All right. As an agent for septic shock. I don't know how many of us have it in our centers. I don't have it. I've not used it before, but it's a new intravenous vasopressor for septic shock, all right, and other form of distributive shock. All right, some studies have shown that almost at 3 hours, almost 70% of patients with angiotensin 2 had reached their target blood pressure, compared to 23% who received placebo and usual vasopressor. Although the study that I'm quoting here was not designed to detect mortality benefit from this agent. But remember that these patients on angiotensin 2 require lower doses of other vasopressors when they are used. All right, so we're done here. I just want to have a clinical scenario so that one or two people can just give us, what they think about these two different scenarios that I've brought in here, just to ensure that we understood all the jargons I've been saying for the past 1 hour. So you have a 65-year-old male patient with history of hypertension and DM, admitted to your ICU with a provisional diagnosis of acute MI. The patient is hypotensive, tachycardic, has cold and climbing extremities. Echocardiography reveals severe reduced left ejection fraction of 25%. Clinical signs of poor perfusion include decreased urine output, which is made only 10 mils in the last hour, and he has altered mental status. How will you approach this patient? Anybody that wants to try, you can unmute, then we discuss it briefly before we bring this to an end. Let me just pause so that I'll stop recording here so that your voice will not be here. So I'm going to stop recording, then we can discuss.